I'm delighted to introduce Ray Estacio from Denver Health. He really needs no introduction because he's widely known across Denver and Colorado. When I moved here, Ray was one of the first people that I met. And when I was starting to work at the Latino Research and Policy Member, all I kept hearing across town was like, "Have you met Ray? Have you met Ray? Have you met Ray?" So he was someone who's been really, truly spectacular. He's in our board steering committee, and he helps the LRPC a lot. And we're always trying ways to try to collaborate. One day we will collaborate. So Ray, thank you so much for coming here. Really appreciate it.
That was kind of over the top. None of that is true. I've worked at Denver Health for over 20 years. It's amazing. And Lily and I were talking in terms of her career moves, and too bad it's not my direction. So I'm kind of sad because she's a wonderful person. But my main job is at Denver Health. I'm a medical director for QI and research there. But I actually spent a longer time at the Colorado Prevention since out of residency. I initially was going to do a cardiology fellowship and looking at heart disease, and then I realized, oh my God, I don't belong in the cath lab. And I was more interested in cardiovascular prevention. And so I got involved in clinical trials for about a decade, studying the roles of blood pressure control in diabetics, and hopefully part of the move to help set standards in terms of what the level of blood pressure control is to prevent diabetic complications in type 2 diabetes. It was nice to see Sheena here. She's a long-time friend, and we did Luchar together. And that was my transition from clinical trials research, which is all about p-values and RCTs and making sure you're measuring every little biometric thing, to focusing on qualitative research. And I remember one of the first things I talked to Sheena about in one of our initial meetings, so I'm ad-libbing right now, is that, wow, you could put a p-value to some of this stuff. That's amazing. So I learned a lot, and she convinced me in that regard that listening to participants, patients, is really important. And it's not just the medications and collecting their biometric data in terms of making sure their quality of life is improved. So I was tasked to talk about Latino health disparities assessment in Colorado. So what I'm going to give briefly is just the health status in adults in Colorado, and then talk about a program that we've been doing now for 9 years. We started in Northwest Denver, partnered with Prayer Results. I saw Fernando Pineda here and Diana. There they are. They're great partners in the community, and they basically led this thing from the start. But we'll go to a little history and some of the results of that intervention we've done over almost a decade now. So just going through the numbers, Glenn did a wonderful job in pediatrics. I didn't go in super detail. I have a few graphs here. This is in the state of Colorado. We have about 5.6 million at least that we recorded living in Colorado. It's, nearly 70% are white non-Latino, and 21%, which is going up, is the Latino population, followed by African Americans, Asian Americans, and Native Americans. So 21% is significant amounts and still going up, and these are adults. When we talk about access to care, the February poverty level always comes into play. And so, as you may know, the February poverty level is you're earning $16,000 or less for a single person, and $32,000 or less for a family of 4. So when we look at the stats, and I'll pull some of it from the CDPHE, when we look at that numbers, you can see here, in terms of Latinos in this second bar, I'll use this, 21%, similar to Native Americans, sit below the federal poverty level. A lot of those patients in the Denver metro areas, I don't know if Lillian talked about it, but is seen at Denver Health. So there's a significant proportion of Latino population under the federal poverty level. When we look at education, which is a predictor a lot of times of health, looking at bachelor's degrees, looking at whites, looking at black, African Americans, Asian Americans, and Native Americans, the Latino population for a male, 7%, for females is 8%, is relatively low. In terms of health coverage, again, Latinos being highlighted in red. In the white, this is any health coverage, 89% for whites, African Americans and Asian Americans, and Native Americans are 68 to 83 and 84% respectively. But you can see here, for Latinos, it's, in Colorado, it's 57%. So a big disparity there amongst the different race and ethnic population. When we talk about, and most of my work's in cardiovascular disease, like I said, I've done for a number of years, we look at cardiovascular risk factors. These are things a lot of times that we can address and control. The four things that I highlight here is obesity, high cholesterol, hypertension, diabetes, and smoking. This, we're looking at whites in the far left, Latinos in the middle cluster, and African Americans in the cluster on the right. As you can see here, when we look at obesity, Latinos have the highest rate of obesity compared to their counterparts at nearly 28%, as opposed to whites at 18.7% or 19%. In terms of high cholesterol, I was surprised when I looked at this data that Latinos are about 29%, similar to African Americans, but the whites had a higher percentage with high cholesterol values or diagnosis of hypercholesterolemia. When we look at hypertension, it doesn't. The Latino population here in Colorado actually are 37. Have a prevalence of 37%, and a lot of us think about African Americans when we think about prevalence of hypertension. As you see here, they're about 10% higher than African Americans in terms of its prevalence. For diabetes, it's no surprise. Both African Americans and Latinos are around 10% compared to 6.3% in whites. And then, and for another modifiable risk factor is smoking. As you can see here, whites are about 16.7%. The Latino population and the African American population are around 22 and 24% respectively. So as you can see here, there's a high prevalence of cardiovascular risk factors which can lead to cardiovascular outcomes. And when we think of complications in terms of vascular disease, we think of renal failure, heart attacks, stroke, and heart failure. And this slide from CDPHE is the age-adjusted death rates per 100,000 population by race and ethnicity, looking specifically at heart disease, which is a bundle of cardiovascular disease, coronary disease, heart failure, sudden death, and stroke, and then death due to high blood pressure. When we look, the order is a little bit different. The blue is the whites, non-Hispanic. The red is blacks or African Americans. The green is white Hispanic. The purple is Asian Pacific Islander, and the yellow is Native American. When we look at heart disease, no surprise, the African Americans have the highest prevalence of this bundled indicator or outcome, whereas Hispanics or Latinos are just below whites with regard to heart disease and strokes, heart disease in prevalence. In strokes or cerebrovascular disease, the Hispanic, similar to the African Americans, are a little bit higher than the white non-Hispanic group, and then blood pressure, African Americans are a little bit higher in terms of cause of mortality. So upon all this, so it's a lot of data. We know that Latinos have a lot of risk factors, and I myself practice about 25% of the time, and I'm a primary care doc at one of our local clinics at Westside Clinic. And 60% of my population to 70% are Latinos, and oftentimes I get frustrated in terms of the quality of care that I actually give them, getting them to control in terms of their blood pressure, if they have diabetes, sugar control, and making sure they're getting their appropriate medications like statins or maybe aspirin if their risk factor is high. I always had a hard time kind of conveying the importance of some of those things. So it was actually in a room sitting with Dr. Kranz is a cardiologist, and a couple other folks talking about how can we affect Latinos. This is right after we finished the Luchar study. I think Sheena gave a talk here, Dr. Bull, about that program that was going on for 5 years. And we said, let's take that model and let's borrow the Community Advisory Committee from Luchar and figure out if we could do something for the Latino population here in Colorado, specifically in the Denver area. So what we did is we created Community Heart Healthy Actions. It's a mouthful for Latinos at risk. Or we call it CHARLAR. We finally refer to it as the child of Luchar in terms of what we do with a focus in the Latino population with a community intervention. So when we first started this journey to create this program, and as I mentioned earlier, I'm a clinical trials kind of guy and work with the FDA to look at which drug is better than for treating heart attacks and strokes and kidney failure. But what we did is we did a community-based participatory approach with the key mandates of working openly and directly and collaboratively with our partners, our community partners, and seeking them out with a goal to really establish a long-term partnership. And I see Deanna there. We've been partners for over about a decade now. And it's a good partnership. She does all the work, and I just signed some of the checks. But so she does a wonderful job. And then we use it based on using promotores. I don't know if I wasn't here this morning. I had clinic. If anybody talked about promotores, they're lay health advisors that work with the community, similar to what Glenn was talking about. But they help with knowing their advantages, knowing their neighborhood, knowing these people, and knowing what hardships they have to go to. Because a lot of times the participants that we eventually enrolled in our programs were the same, come from the same area, same church as the promoters that work for our program. And as I mentioned, they have a lot of local knowledge, which no way I could understand. So one of the ways we developed this program is using a community advisory committee, as I mentioned. I still fondly remember one of the first ones that we had. Not to say university has a bad reputation, but we were sitting in a room, and Diana's smiling over there, and we had a number of folks, and there's one kind of boisterous community advisory committee, Diane Medina. I don't think she minds me calling her out. She looked directly at me and said, "You're one of those university guys, right?" And he goes, "Yeah." And so well, I'm tired of you guys. All you do is get funding. Here, want to answer a question, stay around for 1 or 2 years, then leave us, and then we're stuck with what you have started, and we don't have a program. So to that day, just because she said that, I said, I'm going to make this dang thing last a long time, and so and make it successful. So we use that kind of feedback to help us form this CHARLAR program that we had. They help us identify focus groups and then interview the participants. We did a lot of surveys. We did a walkability in that area, and they gave us feedback on those assessments and telling us not shyly of that we were wrong or right on some of the things. They also had a tremendous great input into the curricula that we use. We had a number of curricula that we looked at. We picked a curricula that we sort of copied and amended from University of Arizona, Dr. Lisa Statton, who worked with border Mexicans, and we kind of amended that a little bit to fit Northwest Denver. So, but the Community Advisory Committee, and we we let them help make the choices in terms of which one would be best for their community here in Denver. And then they always gave us input in terms of what part of Northwest Denver that we should do this in. What kind of environment? Do we do it in local clinics? Do we do it in rec centers? Do we do it in faith-based organizations? And so they gave a big, great input regarding that. And then they also, as we went out in the community, helped us with the messaging in terms of recruitment, then messaging to local businesses in terms of their potential involvement in the program. So what did we come up with? So this is, I don't know how many are familiar with Denver. This is basically Northwest Denver here. And so this is I-25, and so this is just west of I-25. And so our main focus was here. What we decided to do is really partner with faith-based organizations. We tried doing it a couple times with clinics because we were able to get clinic space, but we soon found out nobody showed up. Nobody wanted to enroll in it. But when we moved to the faith-based like Catholic churches and partnered with them, we had amazing response from the community. I prefer it to have been in a clinic because it was for free, and my boss said I could do it there. But the churches, although they were really good, and at small price, we did have to pay rent for the programs. So this is a little diagram of how we develop the program in terms of looking at some of the evidence-based curricula that were out there, reviewed them with a community advisory committee and some folks from university, and then created the program again and the partnerships. So again, I mentioned Creo Results. They're the promotory group that helped facilitate, give us feedback, and I actually taught the classes for the program. We had our senior community advisory committee. We had partnered initially with our local Catholic churches, and CPC is the Colorado Prevention Center, which I present. And then our goal was to improve knowledge and self-management skills, increase walking and total exercise time, make good choices for healthy eating, decrease soda and sweetened beverage intake, increase salads and vegetables, and hopefully decrease body mass index. What did the program look like? So it's a 11-week curricula. They meet once a week. So it's almost 3 months. So in the beginning part of it, and this is what I think a lot of the participants liked, is we held a health fair type setting where we did point of care testing for measuring their BMI, screening for checking their sugars, and checking a lipid panel, and then measuring blood pressure. So we kind of hit the risk factors, and we took a bit of a survey, and a health assessment in terms of their lifestyles, their eating habits. And we kind of put that all together as part of their baseline. And at the end of that little health fair, we usually did it on Saturdays. I don't think we ever did it we did it on Sunday a couple times. But we had about 70 or 80 groups at a time, and we do about 3 or 4 groups per cohort. So we had about 110 to 120 per cohort with 6 or 7 classes. I'd sit there and counsel about 100 people in a 3-hour or 4-hour time period about their risk factors. It was actually a lot of fun because they were genuinely interested, and they were totally motivated in terms of improving their health and getting access to health. As I mentioned, it was an 11-week curriculum where there was health education, skill building, healthy eating strategies, physical activities, activity strategies. Every class started out with some exercise, self-management, goal setting, social support, and walking groups. Then the end of the 3 months, then we did a post and see how their risk factors change and counseled them on that. And then had a fun event in terms of graduation. I admit I'm starting to miss a lot of the graduations, but they're a blast. It showed how bad I danced, ability to dance, but we had some amazing food during the events, and we gave out certificates. And a great memory I had, the very first one I attended, I was totally underdressed. I figured it was just a community program, about 110 participants, and I figured, 20 people will show up. I'm just going to wear like jeans and a polo shirt. And I came out there, and it's like everybody was dressed to the nines. Everybody had a really formal dress. A lot of the males were in suits and a tie, and I was talking about the program, giving the certificates out. I felt so embarrassed in terms of how I was dressed. So I learned from that, and so 20 cohorts later, I dressed appropriately for those kind of things. But it's a fun celebration of their accomplishments in terms of what they did, and I think it's a fun. We have a DJ there. And besides the food, some of the food, I have to admit, weren't healthy, but it tasted really good. So that's the fun part, right? Doing the program. This is the venue of our healthcare atmospheres. We're always looking for volunteers to man the counseling tables, but Deanna has it working like clockwork now. It's like they move one station to the next station. We gather all this information. I get all the labs back, and then I counsel them under risk factors. We use a Framingham risk score at the end to give them a guesstimate of what their cardiovascular risk is, and we counsel on that, and then tell them in the beginning, you're going to learn how to deal with some of this stuff throughout the program during the 11-week curriculum. So the curriculum, as I mentioned, there's 11 sessions focusing on heart disease, diabetes. These are all led by promotoras. So we give them the content. We initially sat with them and making sure they were saying the same things. Now, CREA results are the content experts. They've amended it a little bit and really made it work for them and made it work for the community. So hats off to Deanna back there and her group. So they did an amazing job in keeping this going. But like I said, it focused on heart disease, diabetes, physical activity. There's stretching, there's walking exercises during the time period. Talk about what a healthy weight is. What is blood pressure control? And what is an active, healthy lifestyle? Then we talked about cholesterol, fats, and your health. I think they do grocery tours then, too, in terms of helping shop. Oftentimes what they would have is we have one family member that comes, but they often would bring their spouse to these classes. So it was, like I said, it was well attended and it was very successful. Talked about glucose and sugars, and then eating healthy as a family with a focus on family, and then how to do things cost effectively. And then the last one's a review, and as I mentioned before, the last thing ends with a graduation party, which is a lot of fun. So how well did this do? So we did just recently published in American Journal of Preventive Medicine in terms of some of our results. You can see that a lot of people committed a lot of time here in terms of our findings. I know this is really kind of tough to read. We, at least for this evaluation process, we had about, I think, 800 for the analytical portion of it. The thing that I was really excited about was what percentage of the participants finished the class. We had, remember, this is a community-based program. 70%, a little bit over 70% of the participants finished 80% of these 11 classes. So I think that's a good thing, and a lot of them a lot of them wanted to do it again afterwards, but I said you can only do it once because we don't have that much access to it, because we do it 3 or 4 times a year since they're 11-week courses. So this is, they're obviously all Latinos, and the health coverage was, a lot of them were 10% were current smokers, 30% had high blood pressure, nearly 30% had known diabetes. In terms of risk factors, when you look at Framingham risk score, 16 had 20% or higher for the Framingham risk score, 23% with moderate, 10 to 20%, 60% with low cardiovascular risk. So when we looked at the results, again, these are about 800 participants. I think we've gone through, 1,400 or so now that we've gone through these programs. We looked at physical activity. So you can see on the left, in terms of vigorous exercise, greater than 75 minutes, 150 minutes, we saw a bump up in exercise for those 2 categories. In terms of sugared drinks per week and sugared soda, we saw a decline when we did the post-evaluation. So granted, this is only a 3-month follow-up. I'd love to get money to do longer-term follow-up for these patients, but it was impressive in terms of what we saw. What we also saw, and I pulled this from the paper, is all the risk factors all kind of improved. Any blood pressure, we saw a decrease in blood pressure, a decrease in LDL cholesterol, decrease in sugar, triglycerides, obviously with a decrease in weight, and also, more importantly, a decrease in Framingham risk score from baseline to 3 months. When we look at specifically those at risk population, those with uncontrolled risk factors at baseline or a previous diagnosis of hypertension, diabetes, we saw an even more significant decrease in these cardiovascular risk factors, and all statistically significant. So in summary, I know I'm running out of time. The CHARLAR program, at least from what we evaluated and published, helped decrease the 10-year risk for these patients. Granted, it's a 3-month follow-up. Hopefully, what they learn continues on. What we found a lot is we found a lot of undiagnosed diabetes, a lot of really kind of bad hypertension that needed help, that it was really key to help them get access to health care. So a lot of days after these events, I was scrambling to try and get people into clinics to get their blood pressure controlled, or because half the time I was really tempted to just give them the medication and treat them as myself. But we eventually developed a good program in terms of referrals to community clinics. A lot of them went to Denver Health in terms of getting follow-up care. And then, like I said, conducting the classes, and we tried it in the health clinic setting, was poor attendance versus really partnering with, at least in the Latino community, faith-based organizations, especially Catholic churches. A lot of the promotores know those organizations, and a lot of participants are from those organizations, and shows really, I think, part of the good attendance that we received from that. So I think that's all I have time for. Are there any questions regarding the program? Oh, sorry. Okay. I guess I'm done.